Good evening, everyone. My name is Mohammed Khan from Sinai. I'm going to share this interesting case with you guys. It's a 71-year-old male who initially presented with refractory heart failure, class 3 symptoms, past medical history with hypertension, HIV. He's on antiretroviral drugs, on beta blocker, calcium channel blocker, and Lasix, and continue to have symptoms. When he was seen initially in the clinic and evaluated by us, his blood pressure and heart rate pretty well controlled. He had signs of heart failure with elevated GAVD. He has bibasilar crackle, split S2 and S4, and a systolic murmur at base and apex with peripheral edema. His EKG showed left bundle branch block, first degree AV block, and left atrial enlargement. At that point, the referring physician, he had already ordered an echo, which was available, and we reviewed the echo. So this is parasternal long axis view. You see there is septal hypertrophy. EF appears to be normal. And we go back, so you can see. Yeah, anyhow, I don't know why this is not working. 1 second. All right, anyhow, so it's difficult to see in this view because of the color, but you can see there's a turbulence across LVOT with posteriorly directed mitral regurgitation jet, and the interior mitral leaflet is redundant, is coming all the way across the LVOT. So at that point, we ordered a trans-esophageal echo, and you can clearly see that the LVOT in the four-chamber view, the interior mitral leaflet covers the LVOT. There is turbulence, and there is a posterior jet, and the resting gradient is 87 millimeters of mercury. We proceeded with invasive hemodynamics, and this is classic post-PVC. Depression of pulse pressure and increase in gradient, Brockenborough, Braunwald, Morrow sign. The gradient is around 100 and then increase up to 300 after 2 PVCs. So the LV gram, patient tried to move during that, but you can clearly see there is a severe mitral regurgitation, +3 to +4 with the filling of left atrium. Coronaries were normal. You can see 2 septals from LAD. First one is small and the second one is reasonable size. So at that point, the patient was already having refractory symptoms despite medications. So invasive management would be the next recommendation, but was evaluated by heart team and was deemed prohibitive risk because of history of stroke, cirrhosis, and HIV. So surgical treatment was out of question. So we had a team discussion, and we thought that given that he has interior mitral leaflet, which is long and covering the LVOT, it would be better to go ahead and do the clipping first, and then see if he has a residual gradient. We can proceed with septal ablation depending on what is the residual LVOT gradient. So we proceeded with the MitraClip procedure. You can see interior and inferior and interior puncture. The transseptal puncture was a little bit difficult because of the scoliosis. And you see we couldn't advance the MitraClip guide. We have to do septostomy. And then the guide went into left atrium. This shows the position of clip with the good trajectory with the parallax out. We routinely do this view at Sinai in the RAO position. So this is the leaflets are grasped. The grippers went down. And you see the leaflets are caught in the arms of the clip, and then we closed the arms, and shows that the color that MitraClip has decreased significantly, and you see that mitral regurgitation has decreased. There is still a gradient around LVOT, but the interior mitral leaflet is not going across the LVOT anymore. The gradient immediately decreased from 87 to 38. This is, again, step by step. You see the LVOT, the leaflet, we have the transseptal puncture, we grasp the leaflet, and the LVOT gradient has gone down to 38. So patient tolerated the procedure well. He was extubated. We confirm our leaflet length, and then you see that there is a reasonable size of the interior and posterior leaflet that was grasped. This is the final 3D view, which showed double orifice mitral valve and the decrease in gradient. Next day echo confirmed that mitral regurgitation has reduced, and LVOT gradient is at 30. Patient was discharged. He was seen 3 months in a 30-day follow-up. He was doing very well symptomatically, and his gradient continued to be in 20s with the post 63. So what we propose is MitraClip XTR, maybe an alternative treatment to septal ablation in these patients who are not candidate for surgical myomectomy. This is more of a controlled procedure. You are not inducing an infarct. The risk of pacemaker arrhythmia is less. So if there is a abnormality of anterior mitral leaflet, you can catch the leaflet. You can assess the LVOT gradient, and depending on what is the gradient, may or may not do septal ablation later on. But the longer-term studies will be needed to see whether this is sustained, this gradient, decrease in gradient is sustained, or, is not sustainable. All right, thank you very much.
Fantastic.